This is Jerry Hesch from the Hesch Institute in Aurora, Colorado. And this is a film showing what the anterior and posterior iliac shelf is. And that's my terminology. Several research studies, the first one done in 1985, demonstrated that physical therapists have limited ability to agree on the height of the iliac crest when palpating the pelvis in patients. Now, the iliac crest is the highest part of the pelvis. Okay? So it's somewhere around here. Now, some therapists palpate from the front of the body, okay, and identify what they think is the top. And this is the human pelvis facing forward. And then some people palpate what they think is the top of the pelvis from the back. And there's poor agreement with that. And again, the crest is the highest part of the pelvis, so it's actually on the outside of the pelvis. Okay? Instead of doing that one landmark, I choose to palpate this shelf in the front. It's right above the ASIS. There's a flat portion there, and I call that the anterior iliac shelf. And I just use my extended fingers, and I place it. I find the PSIS, that bump, and I just lay it above it, and I call that the anterior shelf. And then with the patient prone, there is a flat part right in the middle. So here's the middle of the spine. Here's the outside of the pelvis, and there's the middle of the body right there. It's right in the middle, so it's very easy to find that landmark. And Luann Olson is a PT that got a master's degree, and she did a research thesis on the Hesch method of palpation and of passive motion testing, which I call spring testing. And she found good intertester reliability. You know, different therapists would agree on the same on these landmarks. So there's better agreement with this method than using that landmark called the iliac crest. Okay? Now, it's important to palpate these landmarks with the patient laying on their back and laying on their stomach. It is worthwhile to look at it in standing, but we have to be very careful of what we evaluate in standing. Now, my client is very kind in letting me film her. So I'm only filming her lower body, and I'm looking for these bumps on the front of the pelvis. Right there is the bumps called the ASIS, okay? And then I'm palpating the top of the shelf, okay? And it's subtle, you know, as far as I can tell, she's symmetrical. But please understand that inside the SI joint, the movement is only 2 millimeters. Even of glide, you know, of a forward or backward glide, or a forward or backward rotation is only 2 degrees. That's a very, very minor movement. In a full circle, there's 360 degrees. So you look at only 2 degrees of rotation, that's extremely small. So when someone has asymmetry of the ASISs or asymmetry of the anterior iliac shelf, you cannot say your ilium rotated on your sacrum and got stuck, or your sacrum twisted inside the SI joint and got stuck. You cannot say that. The top of the hip, the top of the femoral head, is a rounded bone. And the whole pelvis can move in 3-dimensional space. When people are standing, their SI has moved to end range, and it's stable. In upright standing, the sacrum forward bends 2 degrees of rotation, and it stays there. So any asymmetry of the pelvis is coming from something happening in the legs, maybe a muscle imbalance or a developmental asymmetry. My client here has a slight developmental asymmetry in the shape of her femur. So her pelvis could appear uneven in standing, but it's too subtle for me to see. But she's actually standing with the right femur pointed outward, the foot pointed outward more than on the left side, and that actually balances the knee joints. that actually makes her patella point forward. So it's a normal adaptation of her body to have her foot pointed outward slightly. So I'm not telling her that's bad, they should point forward. I'm saying that's good. Keep the right foot pointed out a little bit. Okay? So when you look at someone's pelvis and it's uneven in standing, you have to do more detective work. You cannot say, oh, your SI is out, your ilium rotated on the sacrum and got stuck. That's nonsense. You can't get that information from a standing posture. Okay? Let's have you turn around. And so the posterior iliac shelf is found by finding the bony pelvis. Ribs are right here, bony ribs. And now we're fresh out of ribs. We're in soft tissue in the quadratus lumborum muscle. And now we come right down and I'm on top of the posterior iliac shelf. And there are movement tests where in standing the therapist will palpate the PSISs. Now lift one leg, lift your right leg up. Good, and I look at movement, now lift the other one up. Okay, and so therapists do that and they look at the PSIS moving and they think that that measures movement inside the SI joint. But if she lifts her right leg up, go ahead and lift your right leg up, your whole pelvis is moving on, thank you, on top of the round femoral head on the left. I cannot say that that's the SI joint. That is absolute mythology. It's been studied. It's been researched and shown that there is so little movement in the SI joint, less than a degree of glide, a degree of rotation, less than 1 millimeter of glide. I simply cannot see that difference with my eyes. So what am I seeing? I'm seeing the whole pelvis, the entire pelvis moving on the other hip joint. So you should never use those tests to say, oh, the ilium is stuck on the sacrum, you need manipulation, or it keeps doing that and we keep trying to align you and therefore it's unstable, therefore you need a fusion. And there actually is a physical therapist who convinces people that that means it's unstable and she encourages fusion. And that is just nuts. That's absolutely crazy. If it moves asymmetrically, then maybe you should fuse the hip joint. Then you would walk like a peg leg. And I'm being very facetious right here. So anyway, this was a lesson on the landmarks, the anterior and posterior iliac shelves. And I'm going to do one more demonstration, and I'll do that on the table, on the anatomical model. So you can sit on that stool there. And again, the SI is so full of ligament, just so many ligaments, that it has very little motion. It functions like a shock absorber. Okay? And the way that I measure if movement is occurring through the SI joint is what I call a spring recoil test. And things outside of the SI joint can restrict movement going through the SI. Postural asymmetries, imbalance of muscle tone, increased muscle tone. And so when I treat someone, I look at multiple directions of movement through the pelvis, and I look for where movement is stuck or where movement is excessive. And so this is an example of someone laying on their back, and I rotate the pelvis back on the right side, and I move this until it stops, and then I add a spring test. And so theoretically, I'm taking up a lot of movement through the hip, through the whole pelvis moving, and maybe the lumbar spine as well. And then hopefully I'm isolating movement in that joint. And you should feel a little bit of spring and a little bit of recoil if you do this properly. So this is called a spring recoil test. And again, I can rotate the whole pelvis, but primarily on the right. It's three-dimensional movement. Move it until it stops moving. That's called taking up the slack. And then I add an additional thrust, and there's a little bit of give, a little bit of spring, and a little bit of recoil. And I do that in multiple directions. I do a basic 16 different spring tests, and then I have some advanced ones as well. So I do it in multiple directions and discern where movement is blocked, and then I treat it to restore that movement. And I trust these spring tests so much more than looking at landmarks and having people lift their leg up, or having them bend forward and seeing if the landmarks move asymmetrically. You can't call that SI joint movement. Okay? Whereas these spring tests, and now I'm doing a spring test on the back of this, on the lower part of the sacrum, you can measure force going through the SI joint, or force that is blocked, or movement that is excessive. One little secret is that when movement is excessive, oftentimes in the opposite direction, movement is blocked. And so, you know, one direction is hypermobile, but the opposite direction is hypo. And when you restore movement where it's lost, it balances on both sides. Okay? So if someone has excessive forward movement when I spring the right ilium, okay, that might be what's called an anterior ilium. And they would have superior motion, but they would have blocked inferior motion, and then they would have blocked posterior rotation. And that involves the whole pelvis being twisted, and we call it an anterior ilium. But again, we can't measure that little tiny movement in the SI. We can't objectively measure that. We can only measure whether movement goes through that or not. And when this is blocked, then I have a self-treatment technique. It restores movement there, and then the direction of movement that was hyper is no longer hyper. So we gain movement in one direction and it reduces movement in the other, bringing it back to balance. It removes inhibition from the ligaments. The ligaments have nerves that relate to muscle function. And when you have excessive tension in ligament, then it turns off muscle function. So this also balances muscle forces through the pelvis. Didn't mean to talk as long as I did. I'll stop here. Thanks very much.